Polycystic ovaries is a very commonly seen problem nowadays. One of the commonest endocrine disorder. Let us call it as an endocrine disorder. Ovary being one of the important endocrine structures in the body, whenever it starts behaving in a way wherein it fails to produce the eggs, it fails to ovulate as it has to do, and number two, it starts producing excess amount of male hormones, right? So totally everything is pointing towards the endocrine dysfunction. So this is an endocrine disorder and it has a complex pathophysiology. Just as we described preeclampsia, which has a very complex, which has not been understood even today to perfection. Similarly, polycystic ovarian syndrome also has a very complex pathophysiology. Steen and Leventhal are the two persons way back in 1930s have described this condition as a ovary which appeared like an egg, right? So that means a smooth surfaced, a chicken egg, smooth surfaced one, enlarged one, shiny, white surfaced, and that condition was referred to by them as Steen-Leventhal syndrome, right? So now we have evolved to a stage wherein we have understood that it is not just the ovulation issue or just enlargement of the ovary, but there is a multitude of symptoms and signs and endocrine abnormalities associated with the condition. And now that is the reason, instead of calling it polycystic ovarian disease, we call it polycystic ovarian syndrome. Across the world, more than 116 million women are affected. Prevalence is around 6 to 8% across the globe. And in Indian adolescents, we see almost around 9% is the incidence of the problem of PCOS. Etiology-wise, it is probably genetically determined because of the familial insulin resistance gene association. The relationship could be also with androgenesis gene, inflammatory cytokine related candidate, and it is supposed to be, if at all we are looking at the genetic angle of occurrence of the disease, it is probably an autosomal dominant disease which is manifesting when lot of environmental factors also come into play. So a genetic disease which manifests with the environmental factors coming into play is this polycystic ovarian syndrome. The pathology is usually three things should be remembered: hyperandrogenism, anovulation, and insulin resistance, right? These are the basic problems that are there. The androgen level could be high, ovulation is not occurring properly, and the third issue would be the presence of insulin resistance. These will show off in various ways. Insulin resistance can show like a frank diabetes mellitus. It can show as an altered glycemic response, or it can show as acanthosis nigricans on the back of the neck or in the axillary region, right? So it can manifest in various ways. Similarly, anovulation can manifest as infertility. It can come to us as irregular periods, infrequent periods. Hyperandrogenism can present with truncal obesity. It can present with hirsutism, right? So varieties of manifestations could be there, but the basic pathology is hyperandrogenism, insulin resistance, and also the anovulation. Cyclical axis function leads to ovulation, steady state leads to anovulation, right? So there is some kind of genetic influence which we discussed, could be related to insulin resistance, or it could be an autosomal dominance which can lead to hyperandrogenic state, associated with any of those genes. Now the environmental factors, the lifestyles, right? The physical activity, the diet pattern, etc., all those things can induce hormonal changes which are exacerbated by the obesity, which leads to increased androgen, increased insulin resistance. All these things act on the ovarian follicles, and this causes anovulation, which also increases so many follicles produced. There is increased estrogen. So this unopposed estrogen, the estrogen that increases and there is no progesterone because there is no ovulation, this increased unopposed estrogen will cause menstrual disturbances, infrequent cycles, and also can cause endometrial hyperplasia in a long run. And insulin resistance is going to cause diabetes and metabolic syndrome, which further aggravates the cardiovascular risk. Androgen excess is going to cause hirsutism, acne, obesity, etc. All together can lead to body image related issues, self-esteem, depression, anxiety, the psychological issues. So at the end, we are going to call it as PCOS, the syndrome which comprises of multitude of problems like hyperandrogen related, hyperestrogen related, anovulatory related, insulin resistance related, all of them leading on to the psychological stress, anxiety, depressions, etc., leading on to polycystic ovarian syndrome. So continuing with the pathophysiology, hypothalamo-hypophyseal related issues are increased LH pulse, increased LH-FSH ratio because of the multiple follicles developing at various stages. LH keeps on increasing with an idea to trigger ovulation, but it fails because there is no maturity, number one, and number two, there is adverse environment in the ovary to lead on to further growth of the follicles, that is hyperandrogenic environment, and increased prolactin. These are caused by the hypothalamo-hypophyseal structures. Coming to the ovarian problem, ovary undergoes hypertrophy, especially the stromal hypertrophy. There is increased androgenesis. Androgenesis is again from the ovarian stroma. Growth of follicle, further development of the follicle is arrested. Arrest of follicle growth is again because of the hyperandrogenic environment, and insulin sensitivity is decreased. There is increased insulin resistance, right? Coming to the adrenal component, there is androgenesis by ACTH, increased sensitivity, and 3-beta hydroxy dehydrogenase upregulation. Coming to the peripheral fat, there is peripheral conversion by 5-alpha reductase, which also increases the estrogen level, and there is increased insulin resistance. So this is the pathophysiology, and pathophysiology occurs from hypothalamus, hypophysis, ovary, adrenal, and peripheral fat. So it's a general problem that involves almost every structure of the body. So what are the clinical features? One is the cosmetic issue. It could be only related to cosmesis. So what I mean is, a PCOS patient can directly approach a dermatologist with some problem. She may not come to a gynecologist always. You can find PCOS patient going to a dermatologist with acne and hirsutism, right? Body related, image related issues, she can meet a bariatric surgeon with a request to do some bariatric surgery, or she might be sitting with a dietitian to asking to get help from her to reduce her weight. They can approach a fertility expert with fertility issues, not able to conceive. Basically, we told you there is an ovulation. She can approach a gynecologist directly with infrequent cycles, and when the cycle occurs, it is going to be a very heavy flow, painless, heavy flow occurring once in 3 months, 4 months, 5 months, 6 months, once a year. So very infrequent cycles. She can sit with a psychiatrist or is being taken by his parents to a psychiatrist with manifestations of anxiety, depression, etc. Or she might have been referred from any of these other specialists to a psychiatrist. She can be with a physician with diabetes. She can be with again a dermatologist with acanthosis nigricans, or it could be again lifespan related issues. So you can find this PCOS patient almost in any of the departments of medical colleges or in the hospitals with varieties of problems, right? The manifestations of insulin resistance could be hyperinsulinemia. She can present with gestational diabetes. She can present with pre-existing diabetes. She can present when you just do a glucose tolerance test on a routine basis. You may find that there is altered or there is glucose intolerance in these patients. She can present with acanthosis nigricans. Metabolic syndrome, central obesity, and hypertriglyceridemia could be the manifestation. Ovarian dysfunction can present with infertility and menstrual disturbances. Hyperandrogenism, I told you, acne and hirsutism of various degrees. Then psychologically, anxiety, depression and poor self-esteem. Dermatological again, all these problems, some of them can be leading on to the dermatological problems. So this is a picture showing a very severe acne. This is hirsutism and this is acanthosis nigricans.